Good afternoon, dear students. Let's start our today's lecture in Propaedeutics of Internal Medicine. And today it is a last lecture in submodule Signs and Symptoms of Cardiovascular System Diseases. And topic of our today's lecture it is Syndrome of Heart Failure. Plan of our today's lecture will include definition of heart failure. We will discuss classification, pathophysiology. We will discuss separately systolic and diastolic dysfunction, separately left and right ventricle failure, what is cardiovascular response, and moreover we will talk about causes, risk factor, clinical classification, clinical picture, diagnosis, complication, and we will have a USMLE test for your self-controlling. And what is heart failure? It can be defined as an abnormality of cardiac structure or function leading to failure of the heart to deliver oxygen at a rate commensurate with the requirements of metabolizing tissues, despite normal filling pressures, or only at the expense of increased filling pressures. Heart failure is defined clinically as a syndrome in which patients have typical symptoms like breathlessness, ankle swelling, fatigue, and signs like elevated jugular venous pressure, pulmonary crackles, and displayed apex beat, resulting from an abnormality of cardiac structure or function. Classification. Yes, you from the first slide you know, and maybe in general you know, that it can be acute and chronic. Another name of chronic heart failure it is congestive heart failure. Heart failure can be with high output or low output. According to what process systole or diastole is affected, it can be systolic or diastolic heart failure. According to what side more affected, it can be left heart or right heart or biventricular failure. According to presence of dilation, it can be dilated or non-dilated. And by cause, we can divide all heart failure on ischemic, hypertensive, idiopathic, and dilated cardiomyopathy. It can be another much more rare causes, much more rare situation, and today we will discuss just the main. What about pathophysiology? In heart failure, the heart may not provide tissues with adequate blood for metabolic needs. And cardiac-related elevation of pulmonary or systemic venous pressures may result in organ congestion. This condition can result from abnormalities of systolic or diastolic function, or commonly both. Although a primary abnormality can be changed in myocyte function, there are also changes in collagen turnover and extracellular matrix. Here you see a scheme, main pathophysiological ways of progressing of heart failure. What the main factors that lie in base of it? It is volume overload in hypervolemia. It can be pressure overload due to hypertension. It can be myocardial disease, yes, ischemic heart disease, myocarditis, cardiomyopathies. And it is a rapid heart rate due to arrhythmias or secondary just palpitation, secondary due to something, some other chronic pathologies. All these factors together, every of them, or they are in complex, will lead to poor cardiac output. And it leads to two main compensatory mechanisms, two main ways how organism trying to compensate this low output. First way, it is through kidneys. It is decrease renal perfusion due to low cardiac output, and low kidney perfusion lead to sodium and water retention. Sodium and water retention lead to increase blood volume. By the other way, the low cardiac output through the baroreceptors in vessels, for example, in carotid sinus, the most typical place for them. Through the baroreceptors, it is receptors that sense pressure of blood, stimulate autonomic nervous system, and it leads to sympathetic stimulation. Sympathetic stimulation features looks like vasoconstriction, increased peripheral resistance. It is pallor, sweating, tachypnea, tachycardia. You know the sympathetic effects. And all it's together, kidney mechanism with water and sodium retention and activation of sympathetic nervous system lead to increasing of left ventricle and right ventricle diastolic pressures. And according to what pressure increased more, it can be features of left or right heart failure. If it is increased right atrial pressure, it lead to elevated jugular vein pressure. It can lead to hepatomegaly, intestinal edema, and poor oxygen intake and GI absorption. And increased left atrial pressure leads to pulmonary edema that, like a pathological cycle, leads to more stimulation of sympathetic nervous system and worsening pressure in left atrium and worsening symptoms of left heart failure. Progression from hypertrophy to diastolic heart failure shown on this picture. In the presence of congestive symptoms, the time course of heart failure may become progressive and may end with a sudden cardiac death or interruptible end-stage failure. And you see that during years, during long time, all these factors like hypertrophy, hypertension, other risk factors like genetic predisposition, gender, age, hypertension, obesity, dietary intake, neuroendocrine factors lead to hypertrophy and structural remodeling. It can lead to some morphological and pathophysiological systolic, diastolic abnormality, some diastolic dysfunction. But when it starts symptomatic of heart failure, when you see clinical manifestation of heart failure, in the progression become much more rapid, and in several months it can lead to death. And the schematical picture that nearly show us the difference between diastolic and systolic heart failure. You see, in diastolic it is mostly thick walls that are very resistant. They are not enough elastic and it not able to relax correctly. That's why it leads to abnormal diastole. For systolic heart failure, most often chambers are dilated, myocardium become thin, chambers become bigger, and this thin myocardium, it is too weak to push enough blood during their constriction. That's why it leads to abnormal systole. Okay, and what it be? It will be in systolic dysfunction. In systolic dysfunction with reduced ejection fraction, the ventricle contracts poorly and empties inadequately, leading initially to increased diastolic volume and pressure and decreased ejection fraction. Many defects in energy utilization, energy supply, electrophysiologic functions, and contractile element interactions occur, with abnormalities in intracellular calcium modulation and chem production. Predominant systolic dysfunction is common in heart failure due to, for example, myocardial infarction, myocarditis, and dilated cardiomyopathy when walls are not able to constrict correctly. Systolic dysfunction may affect primarily the left ventricle or the right ventricle. And often a left ventricle failure leads to right ventricle failure. In progression of disorders, right failure added to left heart failure. Okay, and what you see here on this picture, in pictures A and B, it is left ventricle hypertrophy lead to systolic dysfunction due to pressure overload. And picture C, it is when the left ventricle hypertrophy is compensatory response to stress-mediated diastolic dysfunction and worsening by itself. In diastolic dysfunction, we name it heart failure with preserved ejection fraction because systole here is normal, ejection fraction instrumentally will be normal. That's why clinically we put in classification heart valve with preserved ejection fraction. Ventricular filling is impaired, resulting in reduced ventricular and diastolic volume, increased end diastolic pressure, or both. Contractility and head's ejection fraction remain normal. Ejection fraction may even increase as the poorly filled left ventricle empties more completely to maintain cardiac output. Markedly reduced left ventricle filling can cause low CO and cardiac output and systemic symptoms. Elevated left atrial pressures can cause pulmonary hypertension and pulmonary congestion. Diastolic dysfunction usually results from impaired ventricular relaxation, increased ventricular stiffness due to valvular disease, constrictive pericarditis, acute myocardial ischemia, hypertrophic cardiomyopathy, disorders with ventricular hypertrophy, and amyloid infiltration of the myocardium. All of them more typical more typical diastolic dysfunction. Abnormal relaxation and decreased stiffness are associated with diastolic filling abnormalities and normal exercise tolerance in early phase of diastolic dysfunction. Schematically, you see here, one more time, scheme of mechanism of diastolic dysfunction. Okay, left and right, they are different too. Cardiac output decreases and pulmonary venous pressure increases. When pulmonary capillary pressure exceeds the oncotic pressure of plasma proteins, it is about 24 mm hydrorgium. Fluid extravasates from the capillaries into the interstitial space and alveoli, reducing pulmonary compliance and increasing the work of breathing. Lymphatic drainage increases but can't compensate the increase in pulmonary fluid. Marked fluid accumulation in alveolar pulmonary edema significantly alters ventilation-perfusion relationships. In severe or chronic left ventricle failure, pleural effusions characteristically develop in the right hemithorax and later bilaterally, further aggravating dyspnea. Left ventricle injury leading to structural remodeling and dysfunction to the seminal event in the progression of heart failure. Okay, and what about right ventricle failure? Systemic venous pressure increases because of the abnormal function of right ventricle. It causing fluid extravasation and consequent edema in general circulation, primarily in dependent tissues like feet, ankles of ambulatory patients, and it can be edema of abdominal viscera. The liver is most severely affected, but the stomach and intestine also become congested. Fluid accumulation in the peritoneal cavity, we name it ascites, can occur. A right ventricle failure causes moderate hepatic dysfunction with a modest increase in conjugated and unconjugated bilirubin, hepatic enzymes, etc. The impaired liver breaks down less aldosterone, further contributing to fluid accumulation. Chronic venous congestion in the viscera can cause anorexia, malabsorption of nutrients and drugs, protein-losing enteropathy characterized by diarrhea and marked hypoalbuminemia, chronic GI blood loss, and rarely ischemic bowel infarction. Okay, here you see scheme of right ventricle failure. Yes, usually it starts from increased right ventricle afterload. It leads by one way to right ventricle dilation, and due to this dilation tricuspid regurgitation, and by the other way increased afterload lead to prolonged isovolemic constriction with trying to compensate the situation, increased myocardial wall stress to right ventricle hypertrophy, shift of the intraventricular septum to left ventricle failure. It leads by its own self to right ventricle ischemia and moreover decreased right coronary perfusion, and all it together lead to right ventricle failure. Okay, what is about cardiovascular response? In ventricular function, if ventricular function is impaired, higher preload is required to maintain cardiac output. And how to do this higher preload? The ventricles are remodeled over time. The left ventricle becomes less ovoid and more spherical. It dilates and hypertrophies. The right ventricle dilates and may hypertrophy too. Initially compensatory, these changes eventually increase diastolic stiffness and wall tension, compromising cardiac performance, especially during physical stress. Increased wall stress raises oxygen demand and accelerates apoptosis. You remember that it is programmed cell death of myocardial cells. Dilation of the ventricles can also cause mitral or tricuspid valve regurgitation with further increases in end-diastolic volumes. With reduced cardiac output, oxygen delivery to the tissues is maintained by increasing oxygen extraction and sometimes shifting to oxyhemoglobin dissociation curve through the right to favor oxygen release. Reduced cardiac output with lower systemic blood pressure activates arterial baroreflexes, what I told you in compensatory, increasing sympathetic tone and decreasing parasympathetic tone. Heart rate and myocardial contractility increase. Arterioles in selected vascular beds constrict. Vasoconstriction occurs and sodium and water are retained. It is kidney and sympathetic effects. These changes compensate for reduced ventricular performance and help maintain hemodynamic homeostasis in early stages of heart failure. These compensatory changes increase cardiac work, preload and afterload, reduce coronary and renal perfusion, cause fluid accumulation resulting in what the cycle of cardiovascular response. Primarily, it goes the left ventricle dysfunction, what with the help of anabolic hormones like insulin resistance, inactivity, natriuretic peptide lead to catabolic state. Catabolic state lead to skeletal and respiratory myopathy that can, like symptoms, have this patient muscle fatigue, dyspnea, that it increase ergoreceptor activity and increase ventilation, that just worsening dyspnea. After it lead to sympathoexcitation vagal withdrawal, to vasoconstriction due to sympathetic effects and renin-angiotensin-aldosterone system effects, and to reduce peripheral blood flow that lead to catabolic state one more time. As cardiac function deteriorates, renal blood flow and glomerular filtration rate decrease, and blood flow within the kidneys is redisturbed. The filtration fraction and filter sodium decrease, but tubular resorption increases, leading to natrium and water retention. Blood flow is further redisturbed away from the kidneys during exercise, but renal blood flow improves during rest, possibly contributing to nocturia. Decreased perfusion of the kidneys and possibly decreased arterial systolic stretch secondary to declining ventricular function activates the renin-angiotensin-aldosterone system, increasing sodium and water retention and renal and peripheral vascular tone. These effects are amplified by the intense sympathetic activation accompanying heart failure. These processes cause the cascade of potentially deleterious long-term effects with a myocardial and vascular collagen reposition and fibrosis, vascular and myocardial hypertrophy, thus contributing to the remodeling of the heart and peripheral vasculature, potentially worsening heart failure. One more time cycle of cardiovascular response. You see that from the heart it goes to the brain through the neurohormonal activation. It connected with vessels, connected with kidneys, and one more time you see all this effect in this scheme. But additionally, here shown the role of pathophysiological pharmacotherapy, and on pharmacology maybe you remember such group of drugs like renin-angiotensin-aldosterone inhibitors or diuretics, and they are very effectively affect these links of pathophysiology, and that's why for today it is a first choice drugs for treatment of heart failure. On cardiology you will have more information about it. Chronic activation of neurohormonal responses is detrimental to the normal balance between myocardial stimulating and vasoactive hormones. Beta-1 receptors are downregulated, probably in response to intense sympathetic activation. Plasma norepinephrine levels are increased, largely reflecting sympathetic nerve stimulation, as plasma epinephrine levels are not increased. Vasopressin is released in response to a fall in blood pressure. Atrial natriuretic peptide is released in response to increased atrial volume and pressure. Brain natriuretic peptide, or B-type we name it, it is released from the ventricle in response to ventricular stretching. Fewer endogenous vasodilators are produced, and more endogenous vasoconstrictors are produced, thus increasing afterload. The failing heart and other organs produce tumor necrosis factor, or TNF-alpha. And what we see here one more time, it is complex of mechanisms that worsening heart failure. First of all, it is imbalance between in vegetative nervous system with parasympathetic withdrawal and sympathetic overdrive. It leads to increasing of heart rate. It is increased inflammation with excess cytokine release. It is nitric oxide dysregulation, and it has pro-arrhythmic effect. Age-related changes in the heart and cardiovascular system lower the threshold for expression of heart failure. Interstitial collagen with the myocardium increases. The myocardium stiffness and myocardium relaxation is prolonged with significant reduction in diastolic left ventricle function, even in healthy people. An age-related decrease in myocardial and cardiovascular responsiveness to beta adrenergic stimulation further impairs the ability of the cardiovascular system to respond to increased work demands. Okay, and changes with ages, yes. You see that in young heart, a little bit other structure of cardiomyocytes and another cardiac senescence response. And for more aged people, it is a little bit another stretch of cardiomyocyte with another function of fibroblast, and this process of cardiac senescence response goes in another way. Okay, let's discuss causes of heart failure. First of all, it can't be one exact cause, because I always told that heart failure, it is not a disease, it is a syndrome, and please remember it for one more time. What it means? It means that heart failure can't be primary, never. It always have some preliminary cause. It can be cardiovascular problem, it can be non-cardiac vascular problem, it can be extra body problem at all, but it always present something that lead to this heart failure, to any forms of heart failure. That's why it's not a real disease, it is complication of something else. That's why we name it not a disease, we name it syndrome. What the most often cause of heart failure? It is according to importance in population. It is coronary artery disease, it is high blood pressure, and we name it hypertension. It can be atrial fibrillation, valvular heart disease. It can be not cardiovascular cause, like for example excess alcohol use or severe or chronic infection, or another cardiovascular disorders like cardiomyopathy. It can be caused often in patients with thyroid disease, kidney disease, diabetes, and heart defects present at birth. And risk factors. What risk factors can lead to heart failure? Because we know that some patients with diabetes have heart failure, some patients not. That's why we should find some risk factors, some etiology that lead to in complex several factors lead to presence and manifestation of heart failure. What are these risk factors? It is high blood pressure, it is coronary artery disease too, it is presence of heart attack in anamnesis of patient, it is presence of diabetes and using some diabetic medications, it is presence of sleep apnea and congenital heart defects. Moreover, it can be valvular heart disease, viruses, alcohol use, tobacco use, obesity, and irregular heartbeats. Okay, I named today you a lot of classification of heart failure, right, left, systolic, diastolic by the cause, but what classification we use in clinic to put and detail the diagnosis in your case history? We name it clinical classifications. According to American College of Cardiology, it is one of the most usable classification in the world. It can be divided by stages on A, B, C, D. When A, it is high risk of heart failure but no structural changes and no symptoms. B, it is presence of structural changes, for example, hypertrophy, remodeling, changes of size and form of chambers, but it is still no symptoms of heart failure. Stage C, it is symptomatic heart failure, presence of symptoms, And stage D, it is end stage or refractory to treatment heart failure or heart failure that requires specialized interventions, surgical or mini-surgical, mini-invasive interventions. And maybe the most usable classification in all world, it is classification of a New York Heart Association by the functional classes of heart failure. It can be 4 functional classes according to severity of heart failure. First functional class, it when the ordinary physical activity do not cause under fatigue, dyspnea or palpitations, and no limitations, certainly no limitations of physical activity. Functional class 2, it when the ordinary physical activity causes fatigue, dyspnea, palpitations, or angina. In general, we name that it is mild limitation of physical activity. Functional class 3, patients comfortable at rest and less than ordinary physical activity causes fatigue, dyspnea, palpitations, or angina. Or in other words, it is moderate limitation of physical activity. And functional class 4, it is symptoms can occur at rest and physical activity increases discomfort. We name it severe limitation of physical activity. Clinical symptoms. It can be different and it depends what type, systolic or diastolic, left or right, acute or chronic heart failure, according to form. In general, let's name the main symptoms. It is shortness of breath or dyspnea, it is the most often symptom of heart failure. It is fatigue and weakness, swelling or edema in legs, ankles and feet. It can be rapid or irregular heartbeat. It can be reduced ability to exercise, persistent cough or wheezing of the white or pink blood-tinged phlegm, and increased need to urinate at night. Moreover, it can be swelling of abdomen that we name ascites. It can be sudden weight gain from fluid retention. It can be lack of appetite or nausea, difficulty concentrating or decreasing alertness, sudden severe shortness of breath and coughing up pink or foamy mucus. Chest pain if heart failure is caused by heart attack. And I said that it can be different for left and right. What the more typical for left? The most common symptoms are dyspnea, reflecting pulmonary congestion, and fatigue, reflecting low cardiac output. Dyspnea occurs during exertion and is relieved by rest. And as heart failure worsens, it can occur during rest and at the night, sometimes causing nocturnal cough. In paroxysmal nocturnal dyspnea, a very specific symptom, dyspnea awakens patients several hours after they lie down and is relieved over after they sit up for 15-20 minutes. In severe heart failure, periodic cycling of breathing, we name it Cheyne-Stokes breathing, it is type of pathological breathing, can occur during the day or night. Sleep-related breathing disorders such as sleep apnea are common in heart failure and may aggravate heart failure. Severely reduced cerebral blood flow and hypoxemia can cause chronic irritability and impair mental performance. In right heart failure, the most common symptoms are ankle swelling and fatigue. Hepatic congestion can cause right upper quadrant abdominal discomfort at stomach, and intestinal congestion can cause anorexia and abdominal bloating. The specific symptoms include cool peripheries, postural lightheadedness, nocturia, and decreased daytime micturition. Skeletal muscle wasting can occur in severe biventricular failure and may reflect increased catabolism with increased cytokine production. Significant weight loss like cardiac cachexia, in an ominous sign associated with high mortality. It can be in a very severe patient. In the elderly, presenting complaints may be atypical, such as confusion, delirium, falls, sudden functional decline, nocturnal urinary incontinence, or sleep disturbance, coexisting cognitive impairment, and depression. And one more time, comparing left and right heart failure. In right heart failure, it on the first place congestion, and it is edema of lower extremities, it is ascites, it is liver congestion with impaired liver function, and GI tract congestion with anorexia, GI distress, and weight loss. It is right. What about left? Here congestion in a pulmonary circulation. That's why on the first place goes pulmonary congestion with orthopnea, dyspnea, cough with a frothy sputum, and paroxysmal nocturnal dyspnea. And decreased cardiac output in left heart failure lead to activity intolerance, signs of decreased tissue perfusion, cyanosis, and signs of hypoxia. For putting diagnosis in left ventricle failure, tachycardia and tachypnea, hypotension and confusion because of hypoxia and poor cerebral perfusion may occur. Central cyanosis reflects severe hypoxemia. Peripheral cyanosis of the lips, fingers, and toes reflects low blood flow with increased oxygen extraction. Left ventricle systolic dysfunction include a diffuse, sustained, and laterally displayed apical impulse, audible and occasionally palpable third and fourth heart sounds, and an accentuated pulmonic component, and second heart sound. Pansystolic murmur of mitral regurgitation at the apex may occur. Pulmonary findings include early inspiratory basilar crackles that do not clear with coughing, and if pleural effusion is present, dullness to percussion and diminished breath sounds at the lung bases. For diagnosis of tachycardia, yes, we have auscultation, we have palpation with check of peripheral pulses, and we have ACG. On ACG, we can differentiate, is it just tachysystolia and tachycardia due to sinus rhythm or sinus rhythm, or it is tachycardia with some tachyarrhythmias. And here example, the most danger of them, it is ventricular tachycardia and ventricular fibrillation. In such way, there looks on ACG. Okay, central cyanosis can be caused by abnormal composition of hemoglobin, such as sulfhemoglobinemia and methhemoglobinemia, or decreased in the saturation of the oxygen because of cyanotic congenital heart disease, pulmonary embolism, pulmonary edema that required urgent treatment, and severe respiratory disease. You see on the picture, it looks like this, all tissues are a little bit, all skin a little bit blue colored, and especially in this patient, lips are in blue color. Okay, peripheral cyanosis can be a result of causes of central, the same causes with central cyanosis, and can occur in isolation. Common causes of peripheral cyanosis without central are peripheral vasoconstriction due to cold, Raynaud phenomenon, or beta blocker drugs, reduced cardiac output due to cardiac failure or hypovolemia, peripheral vascular disease or venous obstruction, like in deep vein thrombosis. Auscultatory, what can we hear? We can hear different murmurs and extra sounds, like what the most typical, it can be murmurs like systolic or diastolic according to the cause and according to if it present some valve problems like stenosis and regurgitations of the valves. And remember, please, that valve problems can be like a cause of heart failure, and another way heart failure can lead to valve problems because of remodeling, changing form of heart, enlargement of chambers with insufficiency of valve, and, for example, regurgitation. And all these regurgitations and stenosis we can hear auscultatory or with such method like phonocardiography. Diagnostics of right heart failure. It will be non-tender peripheral pitting edema. How we check it? With digital pressure leaves visible and palpable imprints, sometimes quite deep, in the feet and ankles, and enlarged and sometimes pulsatile liver palpable below the right costal margin. Abdominal swelling and ascites, and visible elevation of the jugular venous pressure, sometimes with a large A and V waves that are visible even when the patient is seated or standing. In severe cases, peripheral edema can extend to the thighs or even the sacrum, scrotum, lower abdominal wall, and occasionally even higher. We name it anasarca or diffuse body edema. Edema may be asymmetric if patients lie predominantly on one side. With hepatic congestion, the liver may be palpably enlarged or tender, and hepatojugular or abdominal jugular reflux may be detected. Precordial palpation may detect the left parasternal lift of right ventricle enlargement, and auscultation may detect the murmur or tricuspid regurgitation of the right ventricle or the right ventricle S3 along the left sternal border. Both findings are augmented upon inspiration. It is symptoms how we check peripheral edema. You see it is digital pressure, and we see some imprints that lift after this maneuver. And it is a picture of patient with anasarca. It is a whole body edema with edema of lower extremities, upper extremities, face, body. In these patients usually present ascites, hydrothorax. It even can be hydropericardium, such as severe edema is. Diagnosis in general for heart failure, sometimes it's based just only by clinical evaluation. Please put attention to it. For putting diagnosis heart failure, you do not need any additional tests, no laboratory, non-instrumental, any visualization, anything. Additionally, yes, but the main tool for diagnosing heart failure, it is your brain and your clinical investigation and conversation with the patient. Additionally to it, what should we use for visualization? It can be chest ray, electrocardiography, echocardiography. Additionally, in some cases, we need a cardiac radionuclide scan and magnetic resonance imaging. Sometimes we do blood natriuretic peptide or brain natriuretic peptide or N-terminal-pro-BNP levels. Other blood tests are not used for diagnosis, but they are useful for identifying cause of heart failure and complications. We usually check kidney function, liver function, lipidogram, coagulogram. We need it in patient with heart failure. And according to etiology, we need some other tests. Clinical findings usually suggest heart failure, but are not usually apparent early. It's very difficult to diagnose a heart failure early. Similar symptoms may result from chronic obstructive pulmonary disease or COPD, or recurrent pneumonia, or may be erroneously attributed to obesity or old age. Suspicion for heart failure should be high in patients with a history of MI, hypertension, valvular disorders or murmurs, and should be moderate in any patient who is elderly or has diabetes. And here you see, like in examples, different situations with complications of myocardial infarctions. Why I included it here? Because all of them can lead to heart failure. And picture by picture, what can we see here? First, it is anterior wall rupture. You see by the arrow. Picture B, it is interventricular septum rupture. Picture C, it is papillary muscle rupture, very dangerous symptoms and very often symptom. Picture D, it is fibrinous pericarditis. Picture E, it is mural thrombus. And picture F, it is ventricular aneurysm. All of them can lead to acute or chronic in different forms of heart failure. Okay, what on chest X-ray? The findings include an enlarged cardiac silhouette, pleural effusion, fluid in the major fissure, or horizontal lines in the periphery of lower posterior lung fields. We name it curly B lines. Maybe in pulmonology I show you curly B lines. The X-ray may also suggest alternative diagnosis like a chronic obstructive pulmonary disease, pneumonia, interstitial pulmonary fibrosis, and lung cancer. ECG. ECG findings are not diagnostic for heart failure, but an abnormal ECG especially shows previous MI, left ventricle hypertrophy, left bundle branch block, or tachyarrhythmias like rapid atrial fibrillation. Increases suspicion for heart failure because it is often causes of it and may help identify the cause. The entirely normal ECG is uncommon in chronic heart failure, but possible. It's very important moment. Absolutely normal ECG does not exclude heart failure. Echocardiography. Echocardiography can help evaluate chamber dimensions, valve function, ejection fraction, wall motions, abnormalities, left ventricle hypertrophy, and pericardial infusion. Measuring left ventricle ejection fraction can distinguish between predominant diastolic dysfunction when ejection fraction in more than 50% and systolic dysfunction when ejection fraction is less than 40%. And be attentive to this fact. A lot of questions in CROC will be about patients with heart failure, and a lot of them about is it systolic or diastolic dysfunction. For this information you need just the number of ejection fraction. Intercardiac thrombi, tumors, and calcifications within the heart valves, mitral annulus, and aortic wall abnormalities can be detected. Localized or segmental wall motions abnormalities strongly suggest underlying a coronary artery disease, but also can be present with patchy myocarditis. With a Doppler echocardiography accurately detects valvular disorders, and shunts can help identify and quantify left ventricle diastolic dysfunction. And here you see picture. Yes, it is presence of changing form. It is enlargement of left ventricle in patient with congestive heart failure. And here you see here intracardiac thrombi. And it is Doppler echocardiography. According to color, you know it, we see a blood flow and can measure its velocity, its volume, and its pressure. And here you see like with the orange color aortic regurgitation through the aortic valve. On this echocardiogram, it is dilated enlarged ventricle 2, and you see here intracardiac throbs. And it was B regimen two dimensions, and we have one dimension, M regimen. According to M regimen, we usually use it to check valve disorders, and here you see a scheme of valve working. For checking the valve working in M regimen, first of all we switch on B regimen, put the cursor on the place of valve. For example, it is aortic valve, like here, and after it we switch to the M regimen, and it's drawn like as such structure. And according to this wave, we understand when the cycle of closing, when the cycle of volume, what the volume of blood goes through the valve, and is it present regurgitation in this valve. And some signs, scheme of different signs, how to evaluate valve working in M regimen in echocardiography. One more time, it is M regimen of different valves. Additionally to the main test, in some cases we need such tests like cardiac radionuclide scan. It looks like this. It can help access systolic and diastolic function, previous myocardial infarction, and inducible ischemia of myocardial hibernation. And you see here a picture. It is with myocardial perfusion. We name it SPECT test, or single photon emission computer tomography. Study, also called a cardiac stress test, is used to evaluate heart blood supply. Two sets of images showing blood flow are obtained, the first following a period of rest and second following a period of stress, which involved exercise on treadmill. MRI imaging. It provides accurate images of cardiac structures and is becoming more widely available. And on the picture you see T2 weighted dartboard imaging of left ventricle long axis showing high signal intensity of left ventricle anterior and inferior wall, a sign of myocardial edema. ATY weighted and dark block imaging early enhancement shows the high signal intensity directly after gadolinium administration in the corresponding area of anterior left ventricle wall. Arrows indicate on this picture myocardial edema. On picture B, on picture C, arrows indicate myocardial early enhancement. Okay, checking of NP or BNP or N-terminal-pro-BNP levels. Serum natriuretic peptide or brain natriuretic peptide levels are high in heart failure. This finding may help the clinical findings are unclear or other diagnosis. When you are not sure between, for example, heart failure and COPD, and you need to exclude heart failure, in this case, in this difficult case, we use levels of NP or BNP or pro-BNP. It may be particularly useful for patients with a history of both pulmonary and cardiac disorders. Anti-pro-BNP is inactive moiety created when pro-BNP is cleaved, can be used similarly to NP and BNP. And for diagnosing of heart failure, we use Framingham criteria. Diagnosis requires the simultaneous presence of at least two of major criteria and minor criteria in conjunction, major criteria in conjunction of the two minor criteria. Major criteria include the enlarged heart, S3 gallop rhythm during auscultation, acute pulmonary edema, episodes of waking up from sleep gasping for air, crackles on lungs auscultation, central venous pressure of more than 16 centimeters of water at the right atrium, jugular veins distension, positive abdominal jugular test, and weight loss more than 4.5 kilograms in 5 days in response to treatment. Minor criteria include the abnormality fast heart rate of more than 120 beats per minute, nocturnal cough, difficulty breathing with physical activity, pleural effusion, decrease in the vital capacity by 1/3 from the maximum recorded, liver enlargement, and bilateral ankle swelling. Complications of heart failure. By its side, heart failure can lead to worsening to encephalopathy, kidney damage or failure, heart valve problems, heart rate problems, liver damage, etc. It is the main target organs. And USMLE test for you, for your self-work, self-education at home. An 84-year-old male with a history of severe emphysema and prior myocardial infarction becomes short of breath with exertion. Physical examination reveals third and fourth polysystolic murmur in cardiac apex. F3 heart sound and rails in a lower lung fills. No lower extremity edema is present. Which of the following is the most likely diagnosis? Be attentive and try to answer. If you listen lecture attentively, it will be non-difficult. Option A, left-sided congestive heart failure. Option B, right-sided congestive heart failure. C, left and right-sided congestive heart failure. And D, cor pulmonale. Please stop lecture here, and if it's interesting for you, try to answer just now. And here explanation for you. That correct answer is A, left-sided congestive heart failure, and explanation why. Okay, for today that's all. With this lecture we finish our cycle of cardiovascular lecture in Propaedeutics, and from the next lecture we will start a new pulmonary or respiratory sub-module. It will be very interesting lecture too. That's why see you in 2 weeks on the next lecture. And now, as usual, everyone who listens to the lecture, I ask to write in comments your name and group. And as usual, if you have questions or comments, you can write it here under the video or in our closed Facebook page under the lecture too. And good luck for today, and goodbye.